911 for fighting infection in your body. And then there's red blood cells, which are these red colored cells that you see. They're about 3.5 to 5.5 million red blood cells in your blood. That's what gives your blood red color. Your red blood cells have hemoglobin in them, and that carries oxygen to different parts of your body. And the most important cell for today is your platelets. So platelets are these tiny disc-shaped cells. They're about 150 to 450,000 is the normal range. So they can range between these numbers. And these cells are so critical in stopping bleeding. We'll talk about that a little more. So how are platelets formed? As you can see here, the first cell that you see there on the right is hematopoietic stem cells. So these cells are the most important cells in your bone marrow that lead to the formation of other blood cells. A part of these cells go on to develop into myeloid stem cells, and these go on to develop what we call megakaryoblast. A megakaryoblast is a precursor cell to your platelet. You get signal from the liver and kidneys. The liver and kidney produce this chemical called thrombopoietin. It signals to your megakaryoblast and says, hey, it's time to mature and become a megakaryocyte. So your megakaryoblast start turning into megakaryocyte, which is this cell with a lot of extensions in it, lots of hands and legs. So this is a multinucleated cell, meaning there's lots of brains. We call nucleus a brain of a cell. It gives instruction on how to function. And it has lots of nuclei, lots of different arms and legs. And then these slowly break down and form platelets. So this is what it looks like when you look inside a platelet. Could I take the mic and move?
Yes. Let's go ahead and take it.
Okay, perfect. So I like to talk about this from outside to inside. So you have this outer coat, and then there's these, there's this inner coat that you see, and then there's granules inside your platelets, alpha granules and dense granules. So these granules are really important storage cells for certain chemicals or storage places for certain chemicals that get released when your platelets get activated. And then you see these are connecting tubules, and this communicates the outer surface of the platelet to the inner surface so that when your platelet gets activated, all these stored granules can get released through these surface connecting tubules. And then there's glycogen, which provides energy to the cell. The mitochondria, again, provides energy to the cell. So it's not just a simple disc-shaped cell. It has a lot of things going on inside it. Okay. That's okay. Perfect. So platelets are an integral part to what we call hemostasis. So what is hemostasis? Is your body's ability or process to stop bleeding and keep blood within your blood vessel. There's different steps to hemostasis. We call it primary hemostasis, secondary hemostasis, and tertiary hemostasis. And platelets are an important part of what we call primary hemostasis. So how do platelets stop bleeding? So the first step is tissue injury. As you can see here, this is where, so say you bump your hand against something, right? Or your arm against something. There's all these tiny blood vessels in your arm that are called capillaries, which are the smallest blood vessels. And a capillary wall breaks, and then you start bleeding. Your blood comes out of this gap. Immediately, platelets are your first line to get there as soon as what we call subendothelial collagen. This collagen in the walls of your blood vessel get exposed. Platelets rush to that spot and do something called platelet adhesion, meaning your platelets start sticking to the surface. So once they start sticking, they undergo a conformational shape change. Just from being a disc, now they start putting out extensions on all sides. They have arms and legs, and they get activated. So this activated platelet now activates other platelets around it and starts sticking to each other. And this is what we call platelet aggregation. You can see that they're now forming a team. They're holding other platelets together and slowly start sealing that space and start aggregating. And finally, each platelet, like we talked about earlier, right? They have those granules inside them, the alpha granules and the dense granules. They start releasing all the chemicals inside them, which help activate more platelets and which help activate the next steps in the clotting process. And finally, you form this beautiful plug, which is called the primary hemostasis plug that seals off the bleeding. So this kind of explains, well, if you have a platelet that's not functioning well, you're not able to form this plug. So when you hit something, typically if you have well-functioning platelets, you form a small bruise. But if they're not sticking like they're supposed to, if you're not putting out those granules, if you have an alpha granule or dense granule disorder, or if you have a problem with aggregation, then you tend to have a lot more bleeding, a lot more bruising. And it is not that simple, right? We spoke of 5 or 6 things in the platelet structure, but there's so much going on inside that really tiny platelet, okay? There is different, as you can see, this is what we talked about briefly, right? 5 or 6 things that are inside a platelet. But over the years, especially in the last 10 years, we've learned that there's so much going on inside a platelet. There's all these receptors, there's signaling mechanisms inside it, and how it activates different other chemicals, other clotting factors. We don't even know 10% of these things. And we don't know to test for most of these things. We're still learning. We're still in the beginning stages of understanding these platelets. So here's what we know. Unfortunately, there's not a very uniform classification of platelet disorders. If you just Google platelet disorder classification, you'll see 10 different or 15 different ways of how platelets can be classified. So the most common or the most severe ones, I shouldn't say common, the most severe ones are Glanzmann and Burnett-Soulier syndrome. We know how to diagnose them, and we know a little bit about managing them. We're still not there yet, but there's so many other conditions, and we call this platelet aggregation defect not otherwise specified. That's a whole big chunk that we don't know how to diagnose or what exactly the cause is. We know to diagnose them. We can say, yes, this is a platelet disorder, but there's not good testing available to figure out. Yes? Right. How do we know? It is well recognized. And when we see patients with platelet disorders, these are the patients that we see have the most symptoms.
These are the most common representation. Like not necessarily.
Not necessarily. They're still 1 in a million. It's not that common. But when we see, say I see 20 patients with platelet disorders, the ones with Glanzmann and Burnett-Soulier have the most severe symptoms. And even within Glanzmann or Burnett-Soulier, there's a spectrum. There's some that have it and barely have any symptoms. And there are some that have it. The symptoms are very, very severe.
Hematologist explained like platelet disorders in general to me
Mm-hmm.
a long time ago, but like eggs, like a carton of eggs. And the reason why is like, if you're not like looking inside the eggs and you crack the eggs, like inside there, you don't really know anything other than there's eggs like in there. And so like there's a label on the outside that says like medium yolk, large yolk, extra large yolk, right? And that will tell you what the yolk inside should be. So like when we're looking at like platelets, like your platelet, like all of these platelet disorders, for the most part, it looks like you have a dozen eggs. And then when you go and you crack the egg, like what's inside them might matter. And like for mine example was like, so mine is dense granules, right? So she's like, hey, in that yolk, your yolk is barely a yolk. It's a little tiny yolk. And all of those things that we know are nutrients from yolk, right? We know like, hey, you don't get, so like go to platelet, she was like, hey, for you in particular, we know that you don't get this particular stuff. We don't know all the things that are
Right.
actually in your dense granules. We just know some of the things.
Right.
And so like her explanation was like, oh, your eggs look like they're there. We crack them and you've only got a dot of a yolk, and each person's yolk has different stuff in it. And we don't know what, like it determines what.
How severe, exactly. So we say, what is the bleeding phenotype? It is not well described what the bleeding phenotype is depending on your platelet disorder. Unfortunately, there's a lot of research on other bleeding disorders, but I often call platelets are the stepchild. We're not paying as much attention to platelets as we should. So, the adhesion defect is Burnett-Soulier. We talked about how platelets come and stick. That's the first step. So if that's defective, you have Burnett-Soulier syndrome. Platelet aggregation defect, you know how they clump, touching each other with certain, it's an integrin called alpha 2B, and that results in 2B3A, and that results in Glanzmann. And then agonist receptor defects. So when you put certain chemicals, you're supposed to aggregate and clump together. If that doesn't happen like it's supposed to, we call it an agonist defect. And then signaling defect, you saw that complex picture, right? Like so many different pathways. Anything that goes wrong in that pathway could be a signaling defect. Platelet granule disorders, you have dense granule and alpha granule disorders. So any of those granules, they can either be completely absent or they can be low in number. And that results in a dysfunction because it's not clumping, it's not releasing those chemicals that we need to clump on time. And then there's platelet cytoskeletal structure, meaning you saw those outer coats on that picture, right? If there's a problem with those microtubules or those pathways, then that can result in structure defects. There are some platelet disorders that increase your risk to cancer, like leukemia. That's a RUNX1 mutation. And then this whole big group of platelet disorders that we really don't know much about or what causes it, but we see defects on their platelet aggregation test. So we'll talk a little bit more about the testing part.
It's kind of like, in fact, like the diagnostic, but it's just with when we were looking at the clotting cascade in general, and like platelet infusion is such an important part of that. So regardless, like if you're factor 7 deficient, factor 9 deficient, factor whatever, right?
Mm-hmm.
We have a platelet issue, an underlying platelet issue. No matter what we're doing to overcorrect here, it may not be sufficient enough because of, our platelets are. So why is there such lack of testing going? Hey, if it's not super obvious here, why are we not popping it? Is it because of platelet conditions? There's so many other factors that you have all these meds for 3 months,
Well, that is one part of it. You have to be off a lot of medications that interact with platelet function, and testing is hard. It's more finicky. So we'll talk about that. A lot of centers don't have access to some kind of testing. Right. Like you don't have centers that can do it. Sometimes it's insurance issues. So, and sometimes when you send it out, the platelets get messed up en route. So it's not good enough and we have to repeat it. Sometimes it takes a year to even get a diagnosis because you can't get those testing done on time. Yeah.
So I know it's not FDA or anything.
Right. So you fall in the last bucket.
They didn't specify it.
So we'll talk about testing next, so it can give you an idea and see what you've been tested for and what you've not, and we can go from there. Okay. Yes. Good question. So adhesion is adhesion to the vessel wall. Where it's broken, they first go and stick to the collagen in that spot. The collagen is the connective tissue under your skin, in the blood vessel wall. So they go and stick there. And then clumping is where they start getting tightly packed. So that each platelet binds to a receptor next to it. And they all start packing in really tight to plug it. So that's the difference. Mm-hmm. Yes. No, that's a great question. That's a very common question that comes up. I have patients coming in with really heavy periods and say, "What? I'm passing huge clots. I have a clotting problem. This is not a bleeding problem." So let's go back and think about it. So your platelets can clump a little bit. So these receptors are not absent, they are present. So you're bleeding so much, and say you're holding your nose like this, your blood sits there for a while and they all stick to each other. And there's other factors in your body that help you form the blood clot too. It's not just platelets. So all of those things play a role and help your platelets, help your blood clot. Yeah. Correct. The clot's not strong enough to seal off that bleeding, but you're still forming a clot and it's coming out.
On Craigslist, like years ago, and they had that silicone stuff that you use in the bathroom, and they did it where they did like a thick layer. No, I'm not joking. They did a thick layer, and it was over stuff that was already there. And then when they put something over it, it went right through. But it went itself. So they showed the difference with like the silicone versus the caulking, and they showed that some of this will stick to this area right here, and it'll stop the water from going through. Some of it will just stick, and then it'll go right through the hole. And I think that
Yeah, no. Mm-hmm.
And I was like, some of it can fix itself, but it won't actually heal the injury at the site. And even though I don't understand the medical side of it, like what you're asking, like it makes sense to tell you that they had that kids program.
Yeah. I mean, you're still able to form it because you have normal coagulation cascade, normal factors, factor 1, 2, 1, 2, 3, all of your other factors, and your 8 and 9 and 10 and all of those. So that helps form a clot, but not effective enough. That's why you'll see that patients with platelet disorders tend to have a lot more bruising and, skin findings versus those with clotting factor deficiencies do not have as much of those symptoms. They have more of deeper bleeding compared to platelet disorders. Again, depends on levels and all of that too. Yes. Mm-hmm. Alpha and dense granule, right? I know. I looked to find an exact incidence. How common are these? And there's not large population-based studies to figure out how.
Pretty much every group they diagnosed.
Mm-hmm. Okay. Yeah, like this one is from the CDC, and they had 3,500 patients approximately with alpha and dense combined. But I couldn't like for Bernard-Soulier and Glanzmann, we say 1 in a million. I couldn't find a number like that for storage pool. And then you see this platelet function disorders, right? Like the general pool, it's like 1 in 1,000 to 1 in 100,000. So there is a wide spectrum of these disorders that we haven't labeled really well, and we don't know the exact incidence. So how does one get a platelet disorder? So when a baby is born, you get one set of chromosomes from the mom and one set from the dad, and you tend to have 23 pairs of chromosomes, right? And then, so if you have unaffected parents who do not have, parents who do not have a known genetic condition, or you test them and they don't have it, it could be a spontaneous mutation, meaning the child developed that spontaneously without any hereditary factors in the family. It could be autosomal recessive, meaning the mom can be a carrier and dad can be a carrier. In that case, there's a 25% chance of your child getting both of those affected genes and having the condition. 50% of your children can have carriers and 25% remain unaffected. And then there's autosomal dominant conditions where you have just one gene affected in the dad, but it's an autosomal dominant condition, meaning it can affect 50% of their kids. Does that make sense? So Glanzmann and Bernard-Soulier are autosomal recessive. There's some conditions that are spontaneous. There are some conditions that are dominant, but we don't know the genetics of a lot of these things. And the way we figure it out is we send genetic testing. If we find a mutation, then we test the parents for it and see if they have it or not. And that helps us determine what the genetics are.
I know that there's like maybe I know like ours with the
Toledo?
like the data aggregate, like there's some labs that only do
Right.
certain things.
Mm-hmm.
Like there's like Toledo lab.
The Toledo lab does electron microscopy, where you're like looking at the platelet under a microscope. Mm-hmm.
That, like, when you like someone tests, for instance, and like it goes into a category of the last like 2 slides ago, you have
Mm-hmm.
like we know it's not the platelets and all that kind of
Right.
At what point is there enough entries of that get into a system, for instance, like I know Toledo is one specific provider that runs that program. Like, at what point is there enough that it becomes a known comparative match? Right. So like my
Right.
is like, at what point was it like, hey, there's enough of these people with this particular variant that we didn't recognize anywhere else. Now all of a sudden there's 72 of these in a population of this many. What point does this now become a categorized?
Great question. So that is the reason for doing more genetic testing. If you notice that your physician says, let's do genetic testing, that's probably because we want to identify more of these mutations. So say I have 5 different patients with some, we call it variant of unknown significance or indeterminate, and that could be something related to a platelet, but a disorder has not been described, then what we do is it all gets entered into the, there is a national database, there is an international database, all these genetic testing labs input their data into it. So, and then there's a panel that sits down I think they sit down every 6 months and they look through all of these mutations and say, yeah, and then they, all these genetic stuff, and then they say, well, we have enough of these. I think you have to have 10 variants. I may be wrong, 10 or 5 or 10, I'm not exactly sure. If they have similar symptoms and they have a similar indeterminate mutation, then it gets converted into a pathogenic mutation.
That's the other thing.
Mhm.
In that, like in the
Yeah, yeah, absolutely.
They have said that she has that lab
Mhm.
We did our genetic testing. We have determined, right? 2 of my daughters have determined, as well as our von Willebrand 3-1. But then our boys, they have von Willebrand. They also have a platelet of unknown whatever significance, as does my husband. And then there's like a crossover, but like I have so many kids.
Yeah, yeah, no, absolutely. When it comes, somebody should write that up and publish it so that we all know what that category is.
We have all the things are also under this one other thing too, and I'm all, well, like I have my own population. I just want to know.
Yeah. Unfortunately, that's way beyond, I mean, I'm not a genetic specialist, and usually they're the ones that sit down and decide that. So symptoms, you all know what the symptoms are. It can vary from a small spot of petechiae to like really painful bruises. And you can have, we call it mucocutaneous bleeding, is a classic symptom for primary hemostasis defects. What are primary hemostasis defects? Platelet disorders and von Willebrand disease. These are the 2 main primary hemostasis defects. And you tend to have more mucous membrane symptoms, more skin symptoms than compared to like a patient who has factor deficiency, who has more joint bleeds and more deeper symptoms. There's risk with bleeding, there's risk with trauma of intracranial bleeds. Yes. Uh-huh.
Well, I'm going to say mom and I hurt a lot. How as a parent can, how am I supposed to help her? Obviously it's not all in get help a bruise. What do I don't know what to do other than long time age, just rest, relax, and
I know that is the most frustrating aspect. And that is a common symptom, like common thing that all my patients deal with. And unfortunately, there's not a great answer to it. We need more research. We need more treatments. The treatments we have available are, we'll talk about that in a little bit, but yes, we say rest, ice, pain management, and then you can take antifibrinolytics, which is Amicar or tranexamic acid. We reserve Novo 7 for like major bleeds, or if it's a significant bleed under your skin, obviously you can take Novo 7. We don't want to give platelet transfusions for minor bleeds because we want to keep it for those conditions or those situations where you absolutely need it and it's life-saving therapy.
Suggest any topical, like I was can't arnica as a tactile experience. And I mean, is there any reason that you as a provider say you can't put arnica on that? Like, I know that when your daughter's experiencing, sorry, I don't know where it was, but back here, like bruises hurt. It doesn't even matter. Like, you don't even have to bruises hurt in general, and
Yeah.
It sucks and it hurts. So like arnica for me, I use arnica as a topical. It at least like relieve some of the achiness of the tissue. That's it for me. Is there any reason as a provider that we cannot use?
Can you tell me what the drug is?
Over the counter,
myself. Arnica is an herb, and it's been an herbal supplement for years. It comes in an oral option. I would not recommend oral option for anyone in this room.
Yeah.
So arnica is kind of like aspirin, but way less.
Gotcha. I mean, any topical therapy should, I personally don't know of arnica. I've not told anybody to use it.
like it's like 14 pathologists.
Uh-huh.
Anyway, if you don't know what your bleeding disorder is, they're like, hey.
Yeah, I mean, absolutely.
It definitely helps.
If there's no systemic absorption of it, yeah.
The thing really no reason not to, is what I'm asking.
Yeah.
Dr. Snell, Dr. Nam, and we're gonna read the Dr. Burton, all of that on it is great. I just want to make sure that for you, that you haven't seen.
I personally haven't seen any of my patients use it, but if it works and it's topical and there's no systemic absorption, absolutely go for it.
That can also help save a lot of as well, like doing 50 minutes of the ice and 50 minutes of sleep.
So the only reason we recommend ice more than heat is the vasoconstriction, but if it's symptomatically better, yeah. 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 So bleeding in individuals who menstruate is a big problem, obviously, right? When you look at the number of platelet function disorder, like platelet disorders diagnosed, even though by genetics it can affect both males and females, majority or more than 2/3 are females. This is because of heavy menstrual bleeding and bleeding after delivery. And a lot of times patients get diagnosed because of this, because that's, I mean, and patients a lot of times assume that it is normal. Like I've seen kids tell me, well, I've specifically asked them, are your periods heavy? And they'll say, no, they're not. And then I ask a follow-up question and say, how many days do your periods last? 10 days. But they think it's normal. Right. Exactly. Yeah. I've been asked why, what is an abnormal period, right? Typically, the definitions are if your periods are lasting more than 7 days, that's not normal. If you're having to change your menstrual product every hour or every 2 hours, that's not normal. If you're passing huge clots bigger than a size of a quarter, that's abnormal. If you're flooding all the time, if you have gushing of blood, if you're, missing school, if you're waking up in the middle of the night, soiling your clothes, even if you're wearing like, right. So any of those things is heavy menstrual bleeding. And then a lot of bleeding after delivery is something we see. We have several patients that are diagnosed in those situations as well. So how do we diagnose? The first thing we always do is get blood counts, get a CBC. We look at what your white cell, red cell, and platelet count is. Then we do what we call a peripheral smear. Many of you may have seen pictures of this. As you can see up here, this cell up here is the platelet. When you look at a peripheral smear, it looks just like a small dot. But in some conditions, they look abnormal. So we, as hematologists, majority of us look at peripheral smears on patients with platelet disorders or whoever comes with bleeding condition. So if your platelet looks really big, you see that this is a red cell. Here, if you compare the platelet to the red cell, it's pretty small, right? Versus in this condition, or Burnett-Cilier, you see they're almost the size of a red cell. They're pretty big. And over here in this Wiskott-Aldrich syndrome, the platelets are really tiny. And we look at also an index called mean platelet volume on your blood count, and that tells us how big or small your platelet is. And based on that, we can guesstimate if this could be a large platelet disorder or a small platelet disorder.
Is the reason for like clear out of all the other things because we're checking the efficacy of the platelet, or does it change the shape of the way that they look under the smear if you don't go full clear? What I'm saying is like if someone just walks in and they do a platelet study and you're looking under a smear, you're looking and see the shape and what the platelets look like. Is that different if they have done a full clear out of all of the medications they're not supposed to have in order to?
No, so the peripheral smear just gives us an assessment of what the shape looks like. No. That shape change can only be seen with a very specialized microscope called an electron microscope. In a simple microscope that we have in our clinic or in our lab, we won't be able to say shape changes. We can tell. Correct. We can only see the size and we can see the number. We cannot determine function based on that. Okay. Yeah. Mm-hmm. Absolutely. Yeah. Sorry, we skipped this. So this test is called platelet glycoprotein flow cytometry. What this does is we're specifically testing only for Burnett-Cilier or Glanzmann with this test. You're sending your blood through a flow tube, and then there's a laser beam that's hit on the blood, and there's a light detection system. And based on that, we're identifying these specific receptors, which is basically the GP2B3A receptor, which is defective in Glanzmann, and the GP1B9 receptor, which is defective in Bernard-Soulier. So this is a very specific test. It's easy to get it done. Most labs have it. It's a flow-based test. So this is something that your center should be able to do it for you. And it is an easy, quick test to rule out Bernard-Soulier and Glanzmann. And then platelet aggregation test is considered the gold standard test, meaning if somebody has an abnormality in this test, that is diagnostic that they have a platelet function disorder. Okay, there are certain patterns that we see on this. So say a patient with Glanzmann could have a certain pattern and they say, yes, this looks exactly like Glanzmann. For Bernard-Soulier, there's a specific pattern, but there are conditions where there's not a specific pattern. There's some abnormality. That's probably what you had. And we call it a platelet function disorder. So the way this works is, these are two different methods. This is called light transmission aggregometry. This is called whole blood impedance. And you basically add different types of chemicals, ADP, epinephrine, arachidonic acid, thromboxane A2, all different kinds of things, and see how your platelets react to it. So you see this little curve up here. So as soon as you add your reagent or whatever the chemical is, there's a shape change. Remember, we saw in the first slide how platelets change shape. So there's a shape change, and then it goes up. And around here is where those dense granules and alpha granules release all the get released, and those chemicals come into play, and further aggregation happens. So we expect to see something like this when we do the testing. And if we don't see that, or say this curve goes up until here and then stops, it doesn't do anymore, then we think, okay, maybe it's a release problem. And then if it stops over here, it doesn't even change shape, then we know that there's what kind of problem is it, an adhesion problem and all that. So this test has been the oldest test, and it's still performed in majority of the centers because this is the best test we have right now to determine if your platelets are functioning normally or not. A lot of times we do it, and then there's one chemical that's your platelets are abnormal for, and then we say, well, we have to repeat it again to confirm that you really have it, because it could be influenced by the medications you're taking. So we make sure that you're off all medications, not taking even ibuprofen, we repeat it. And if it's still the same abnormality, then we call it a platelet function disorder. And if it doesn't fit any of the patterns, then it's unspecified. Platelet disorder is what we call it. Yes. Correct. You have to have at least. Then we do genetic testing. Yeah. Yes. If your platelets are less than 100,000, we can't do this. Yes. Mm-hmm. Yes. Sure. You're welcome. Okay. This is platelet electron microscopy, what we talked about. So the picture on the right shows you an electron microscope, which is a very sophisticated machine, a huge machine. There are very few labs. I think there are only 4 or 5 labs in the country that have it. And it's a send out lab. It needs to be made sure that your lab prepares those slides properly and sends it to them, because a lot of times by the time it gets there, you saw how all the changes happened in each of those platelets, right? Those changes can happen en route, and we may not be able to see those granules because those granules get released already. The platelets are already activated because of all the shaking and the moving and all of those things. So your lab really needs to be trained on how to send this. And once they see it, a lot of times when they look at it, the pathologist there is able to say, this is not a good sample. Please send it to us again. It is a very frustrating process because patient has come in, given the lab. They may live 3 hours from where the lab is. Yes.
And they came back different results at different times, because one of that probably is the preparation. And if it is because of the preparation, are you more likely to or not if there was a bad preparation?
So if it is a preparation issue, the pathologist who looks at the slide will be able to tell you that these platelets, there is an issue with how it was transported. This does not look normal. The slide preparation was not good. Usually the person who reads it will be able to tell you exactly that it's good or bad.
Is it vastly different numbers if we had this more than once?
Because of the processing. So are you asking, like, because I'm good question. Like, if you did it the local lab,
Right.
you're same thing, right? And so it's like, oh, hey, right here at this lab, but then they sent it away to the specialty lab, but we don't know the way that it's handled and transported. And now we got two separate results that look correct. That's the difference.
Yep.
So I put it 40% and 1 is 0.
And it also depends. Nothing. Yeah. Yeah. I know. It is very frustrating. Which one's right? In those situations, I go by what did the platelet aggregation show? What, like, did it act like there was a problem or was it not? Right? If your platelet aggregation was no abnormal and you're having a lot of mucocutaneous symptoms, then I may believe the zero, like the less than 10% or whatever. But if you're not having any symptoms and your platelet aggregation looks good, I may believe that it's higher and it was lower because of preparation issues. Yeah. Yeah. What is the bleeding phenotype? What does the platelet aggregation study show? Could it be this? And worst case, there have been situations where we have sent it a third time because we want a definitive answer, and we put it in the blood requisition that, hey, this happened twice. This is what we have. Please make sure the preparation is good and all that before you analyze it. Yes. 4 or 5 labs. The electron microscopy. Yep. Mayo. Majority of centers send it to Mayo. I know Toledo used to do it. I'm not sure if they still have it open. So Toledo has it. I think Cincinnati does. I'm not absolutely sure, but and there's some lab on the West Coast as well. Yes. Yeah, absolutely. Yeah.
If you're in like where you're at, like check and see what provider.
Where are we with time? Yeah.
Can I just interrupt for 1 second? Please know that there is time after for presentation questions and answers. Oh, and you know, we have only so much time, so I want to make certain that you maximize what you have in your presentation. Those are questions, write them down if you think you're going to get them, because I know that I will be that person. Like, if I don't have it now, I'm going to forget it. But we will probably go to about 10:50. We're going to take a little.
What time is it now?
It's about 10:39.
Okay, we got 10 minutes. Okay,
Yeah, and then we'll come back and ask all questions.
that sounds good. All right. So this is what it looks like under the electron microscope. You know how we talked about this picture? That's essentially what we're seeing. This is not something we can see in our clinic under the simple microscope. So these are your alpha granules. These are your dense granules. And they're able to see this, give us how many dense granules do they see under the microscope. If it's low, then we call it a dense granule disorder or an alpha granule disorder. So genetic panel, like we talked about earlier, if your platelets are low, we may not be able to do an aggregation test. We may not be able to do an electron microscopy. Then we resort to genetic panels. So there are many different genetic panels out there. There's many different companies or labs that offer genetic testing. Some have 30 genes in them. Some have 40, some have 50. At the end of the day, my big thing when I do a genetic panel is to make sure it is not one of the conditions that can predispose you to leukemia or some other condition. That is huge for me because in those situations, I have to do bone marrows on these patients once a year to make sure they're not developing leukemia. I have to do screening tests. That is my biggest piece to do it. Obviously, we want to get answers, but when I do genetic testing, I always tell my patients that we may never have an answer. We're doing this, we're only testing for 30 genes. And you guys saw how many different pathways exist. And your insurance may only cover the 30 gene panel, may not cover the 50 gene panel. So we may never know. And they only cover one genetic panel. So unless you're willing to pay out of pocket, we may not be able to do the 50 gene panel and miss out on those 20 genes. But the most important piece is to make sure of the conditions that we know that predispose to cancer, we rule them out, take them out of the picture. If it's a variant of Glanzmann or, Burnett-Soulier, we're able to figure that out. And then obviously we're able to catch any of those variants for unknown significance and document them so that 10 years down the line, we're able to diagnose and give a name to these conditions. No, I mean, majority of the time, yeah, we usually say we don't have an answer yet. And a lot of times it's really hard to convince insurance companies. I have several patients that are denied. Then I have to do what is called a peer-to-peer. I have to call them, talk to them. And then they say, well, it has to be moved up the chain. Somebody else needs to talk. It's a whole, I spend so many hours a week dealing with insurance and figuring this out. But it's a very time-consuming process, and it's very frustrating both for the patient and for me, right? So how can you do genetic testing? Say if there's family history of platelet disorders and we need to do it when somebody is pregnant, we can do something called amniocentesis if you absolutely want to know during your pregnancy. In newborn period, we can do a heel prick and get blood and send that for genetic testing. You can do buccal smears, meaning a smear from your mouth. You can send saliva. You can send blood for genetic testing. So treatment options. The most common treatment that we all prescribe is antifibrinolytics. The way this works is it's in the name. So fibrin, meaning you're forming, that's the last step. It's a fibrin mesh that forms a nice clot and stabilizes it. And then your body doesn't want you to keep clotting. So there's mechanisms to break down that clot in your body, and that's called fibrinolysis. So these medications are antifibrinolysis, meaning they prevent that clot from breaking down by that breakdown process. So aminocaproic acid or Amicar, tranexamic acid, Lystata, these are the common medications that are prescribed. Amicar, majority of the time, is prescribed as a liquid. Amicar pills are bigger than tranexamic acid pills, and most patients prefer tranexamic acid or Lystata. We usually use liquid Amicar for like mucus bleeding. So if you have a tonsillectomy, adenoidectomy, we'll give you Amicar, or any dental procedures. Same thing with Lystata. We typically prescribe it for heavy menstrual bleeding or any soft tissue bleeding. We know that if you have a muscle or soft tissue bleeding, say you have a painful bruise, taking oral pills could help because they're going to prevent that clot from breaking down, help it stabilize more. So if you have soft tissue bleeding, you can definitely try Lystata or tranexamic acid and see if it helps. In some situations where insurance may not cover Amicar liquid for an adult. It's always a struggle. So you could crush up tranexamic acid, make it into a little paste, and topically apply it in places where you're bleeding. Say if it's a dental procedure and you're bleeding from that site, you can absolutely apply a paste form of tranexamic acid. I know. Uh-huh.
And did a compounding tranexamic acid for all kinds of, like, if you have like fissures and stuff like that. And did a tranexamic acid nasal spray because they didn't have the Amicar available. So they did like all of those, and then so they can like write a compounding for it.
That's awesome. Some insurances won't cover for compounding. Oh, okay. Okay.
Yeah.
Good to know. Desmopressin is the other medication we can use for platelet function disorders. We used to have Stymate. It's not available anymore. The Hemophilia Alliance does have Stymate available. I think it's a little bottle for 10 sprays costs around $300 to $400. You can get it out of pocket, but insurance won't cover it because it's a compounded medication. Desmopressin is available as IV injection. So we could, instead of a platelet transfusion, if you have a milder bleeding disorder, we could give you desmopressin pre-op so that you have less bleeding. And then desmopressin is also available as subcutaneous shots. We've started using more of subcutaneous shots after Stymate went out of the market. And it may be, depending on your weight, 2 shots or 3 shots. You give it once. I've used it mostly in patients with heavy periods, where we use it on the first day and then use it again on the 3rd day. It has helped improve some symptoms in patients. If they typically respond to desmopressin, then you can definitely use Stymate as an option. Yes. It's amount that their bleeding will reduce. Yeah, the flow. Oops. Okay. And then recombinant factor 7A, we tend to use it mostly for Glanzmann or Burnett-Soulier, depending on the severity of bleeding. The way this works is I want you to focus on the bottom part. We talked about this, a broken blood vessel, platelets get activated, and now you're forming a clot. And what helps in making a clot are all these clotting factors, thrombin, fibrin, and you have a nice mesh of a plug that seals off bleeding. So factor 7 is one of these clotting factors. So what we're doing here is instead of giving you platelets, we're giving you factor 7 so that this part of the coagulation cascade overworks and tries to compensate for what the platelet's not doing and makes you clot. We tend to use this for surgeries as much as possible to minimize platelet transfusions. It is only given IV, and the other disadvantage is the frequency of dosing is every 2 to 4 hours. Sometimes we can do Q12 dosing, but 2 to 4 hours is the most effective way of managing it. Yes. Yep. Yep. Yeah, I mean, that's why you have to give it IV, and it doesn't work really well after 4 to 6 hours. So we tend to dose, if you've had a major surgery, we tend to dose every 2 to 3 hours and then keep that going. And then if you're doing really well, maybe by day 3 after surgery, we say, okay, let's try Q12 dosing, but you do a higher dose. Yeah, but there are some studies showing that you can do every 12-hour dosing, but it's going to be a higher dose. But in the immediate postoperative period or during an acute bleed, we'd have to do 2 to 4 hours. And then fibrin sealants, these are topical medications that can be used, like for dental procedures and stuff. If your dentist notices that you're having a lot of oozing from that site, they can use a topical thing. So like we talked about earlier, right? Thrombin, fibrinogen, all part of the coagulation cascade. You're basically injecting it on top of that site and help seal it so that it doesn't bleed as much. This is used a lot in surgeries as well, where you have internal bleeding, then they're not able to use it. They can definitely use fibrin sealants. Obviously, it has to be at a big enough center that they have experience using it. Your neighborhood dentist may not have it, so you may be going to a dentist that has experience with treating bleeding disorders. Last but not least, obviously, platelet transfusions we know work, but we try to minimize it as much as possible. The reason being, this is our last resort. If you have major bleeding or a life-threatening condition, this is the only thing we know will work for sure. The reason we save it is because you can develop antibodies against platelets. Your body can start fighting against platelets. So we don't want to expose you to platelets unless we really, really have to. So only in life-threatening bleeds or like a major surgery, we absolutely, if you're doing brain surgery or heart surgery, we say, well, let's just give platelets beforehand. But other than that, we try to minimize the use of platelets as much as possible because of the risk of platelet refractoriness. Yes. HLA match should be okay, but I still, there is chance of antibody development. If there's something else you can use, I would rather use that. Heavy menstrual bleeding, a lot of you around here may have dealt with it. There's treatment options. There's a lot of stigma around using hormones. It's marketed as oral contraceptive pills, but the indication we're using here is as hormone therapy for heavy periods. There's 2 main types of hormones, estrogen and progesterone. There are progesterone-only pills. There are combination, which is the typical combined OCP that you get. There's a patch, an estrogen patch that you can get. There is a subdermal implant, which goes under your skin that is usually just progesterone. There's injections, which is your depot-medroxyprogesterone, depot shots, which you get every 3 months. That is also only progesterone, no estrogen in it. There's intrauterine devices, which can be copper or hormone. It's just local, so you don't have the systemic or all body side effects that you get with pills that you take. And then last resort, we have some patients that have completed their family, still have a lot of bleeding, then hysterectomy is an option because you don't want to continue to bleed all your life if you don't have to. Bone marrow transplant. So this is an option for patients with severe platelet disorders, specifically Glanzmann and Burnett-Soulier. These are the ones that have been transplanted that we have some data on. So you're collecting stem cells from a donor, you process them in the lab. What we do is give chemotherapy to the patient that's going to receive it, essentially completely kill their bone marrow, and give them these new cells that are going to now graft and take place of their old cells and start now producing normal platelets. This goes back to that second picture we had at the beginning of the talk, right? You had those hematopoietic stem cells that developed into megakaryoblast, megakaryocyte, and then platelets. So you're essentially deleting what the person has, and then you're giving new hematopoietic stem cells so that they start developing normal platelets. I mean, transplant is not without side effects. It has its own side effects. There's immune compromise and all of those things, but it's worth discussion with your transplant team to see if you're a candidate for it. And if that will remarkably improve your quality of life, absolutely think about it. Somebody had a question? No. Yes. Mm-hmm. Yep. But there are good reports of complete cure as well. So it depends on how much your disease is affecting you, if you need it or not, and you understand the risks that come with that. So iron deficiency is a big problem. And we all know that with all the bleeding that we have, there is risk of iron deficiency. The way we screen for this is get CBC, which is blood count, and then we test for the storage form of iron called the ferritin. So why does this happen? So here you see the blood vessel. It has all these beautiful red cells floating in it, like 3.5 to 5.5 million red blood cells in your blood. And each red blood cell inside it has this molecule called hemoglobin. And inside each hemoglobin has 4 atoms of iron, 4 molecules of iron. And these iron, and this is extremely important for carrying oxygen to different parts of your body. So when you lose blood, you're losing red blood cells. And we're losing red blood cells, we're also losing iron. And therefore, when you're losing too much blood, you become iron deficient. And you need iron to make hemoglobin. So if you're iron deficient and you continue to lose blood, your hemoglobin is going to keep dropping, and that gets to a point where you're not able to compensate and you need a blood transfusion for it to get better. So ideally, we should all be screening at least once a year for iron deficiency, get a CBC and iron. Most centers do it. Some centers don't do the iron part, but it is worth asking your providers to check for iron levels as well. Iron tastes nasty, especially the liquid form. And the tablets are bearable. There's so many different types of iron formulations available. For the kids that I treat, I don't get any cuts from Novoferrum, I promise, but my son loves it. I have a 6-year-old and a 2-year-old. They love Novoferrum. It tastes so much better than the regular ferrous sulfate. Insurance will not cover it. You have to pay out of pocket. I think a bottle costs about $20, $25. The chewable tablets are great too. They're essentially like candy and kids love them. So if you have somebody that needs to take iron, definitely try Novoferrum. But our goal is to get your iron level up. If you are constantly iron deficient, it's worth taking multivitamin with iron to keep your iron levels up. And then, of course, there's IV iron. We have several people that cannot tolerate oral iron, have abdominal pain, constipation that can make things worse. There are so many different types of IV iron that are available. So there's so many different types. The majority of people use Infed, which is a single, or iron dextrin, which is a single dose. It runs over an hour, hour and a half. You typically get a test dose, and then you get the infusion. Most patients, the good thing about iron dextrin is that it is a one-time dose versus iron sucrose or Venifer is the other one. You have to have multiple doses. There's a max dose of 300 milligrams. So how we do this is we see what your hemoglobin is and calculate what your iron deficit is. And based on that, we decide how much IV iron you need. And if we're giving you IV iron sucrose, then we divide that into 300 milligram doses or whatever the dose the provider decides. And then you have to come weekly versus Infed can be just a one-time dose. There's risks of anaphylaxis, there's risk of allergic reaction, but if you're not able to take oral iron, this is the option. You need to understand the risks. So this is not offered up as the first option. We want you to try oral iron. It's cheaper, has less, complications overall, but if you have issues, then we can obviously give IV iron.
For IV iron, and not being like I know my you do particularly do anything in conjunction with adjunct therapy for like absorption of the IV iron. Like for instance, like my doctor writes a script, I have to have obviously a fluid, I have to have some vitamin C. I have, like, there's certain things that to maximize my absorption, like not only am I iron deficient, but obviously my saturation is very low.
Mm-hmm.
So maximize that.
Not
How does your particular regimen for right?
No, so for IV iron, so the absorption part matters the most for oral formulation, where we definitely say taking it with orange juice or any vitamin C really helps. For the IV part, no, we don't. We just encourage good hydration. If they're dehydrated, obviously we can give fluids. I don't want them to have a reaction to it. But for the IV formulation, it's just the IV form.
That's
Gotcha.
part of that.
Yeah.
Stuff and practice to like, hey, get onboard fluids, you've got to onboard certain.
We always keep fluids ready just in case your blood pressure drops, but that is not necessary. This is the newest treatment in the pipeline, and I'm hoping we have more treatments like this come up. It'll be amazing if this drug gets approved. So this is HMB-001 from Hemab, and the way this medication works is it's a subcutaneous medication, so it'll be an injection under the skin, like Hemlibra for hemophilia. And so you have, that's the molecule, and it binds to factor 7 on one side and an activated platelet on the other side. So here's where, you've had that breach in your blood vessel, your platelets get there. This now has arms and legs, so it's an activated platelet. This drug binds to this activated platelet and binds to factor 7A. So it's essentially bringing factor 7A to that site to help with the clotting process and keeps it there longer. So it's prolonging the half-life of factor 7 in that spot. That way it helps with clotting. So if there's a trial near you that's open for this drug, absolutely participate. That's the only way we're going to get these things approved. But it has very promising phase 1 and phase 2 studies. Phase 3 studies are rolling out. So if you're close to a center that offers this, definitely take it up. That's only for Glanzmann right now, but the hope is if it gets approved for Glanzmann, in the future, we'll be able to use it for other platelet disorders. Yes. I think they might. Hemab is probably here today. I saw a little, oh, there he goes. Yeah. Yeah. No, I didn't know you were from Hemab. Okay, new treatments in the pipeline. There's gene therapy, there's promising animal studies, but it's going to take a while for this to come into action, but we keep the hopes alive. So what can you do while we wait? I think we're probably out of time. I don't know what. Okay, this should be quick. You already know this, but it's just a gentle reminder. Brushing your teeth twice a day, flossing, all of this is important because the most common procedure we see in patients with platelet disorders is dental procedures, dental extractions. These are situations where you can have bleeding excessively and then we need to give you more medication, sometimes need platelet transfusion. We don't want to go there at all. So please take care of your teeth. That'll help take care of your gums because gum bleeding is awful as well. Okay, sports. So, having a bleeding disorder, obviously, we don't want you to be very active in contact sports. So this is something we use for hemophilia. It's called playing it safe. Unfortunately, there's nothing developed specifically for platelet disorders. So you take it with a grain of salt. We usually say don't do anything in red. Those are the contact sports. And depending on your bleeding phenotype, sorry, this picture is not great, but just Google playing it safe hemophilia. You'll find there's a whole document. You can do the yellow and you can absolutely do the green. The yellow and the orange you decide based on what your bleeding phenotype is and if you can do it or not. Again, talking with your physician is what's going to help you decide, but it is really, really important to stay active. Having a platelet disorder does not mean you are not active because we know platelets have so many roles. They probably have a role in your bone development as well. We don't know yet, but keeping your bones and muscles active really helps with development and prevent osteoporosis in future part of your life. Medications to avoid. We typically say no NSAIDs, no aspirin, no ibuprofen, right? So I'm going to spend a minute here. So there's 2 enzymes. There's COX-1 and COX-2. And then these, you can see there are some prostaglandins that are responsible for pain, inflammation, fever. And there's some prostaglandins that are important for renal stuff, stomach protection, and platelet function. The reason we don't want patients taking ibuprofen or aspirin is because we don't want it to affect your platelet function. Okay, so Among NSAIDs or non-steroidal anti-inflammatory drugs, there are non-selective, semi-selective, and COX-2 selective. So it should be okay to take COX-2 selective because you're not affecting your platelet function as much. So if you've never tried it, celecoxib or Celebrex is one of those drugs that you can take for pain. So if you have painful bruises, that is definitely an option that you can try. Most of the time, Tylenol doesn't touch it. So celecoxib is definitely an option that you can try. It's taken as 100 milligrams, starting dose up to 200 milligrams. Medical alert devices, you know, doesn't have to be boring, doesn't have to look like this. So many different options out there. Things that can go on your shoe, on your phone, things that could go on your car seat. I have some patients that have tattooed it as well. Or it can go, I have girls that wear colorful bands that look really good. So look for a nice option. I usually say start wearing them young so that you get used to it. I find it really hard to convince teenagers to wear medical alert bracelets versus those teenagers that started it when they were 5 or 6. It's part of their body. They're so used to it now. Yeah.
Put it on their book bag. And it comes with a book bag sleeve, so they don't wear it on their wrist. They have it on there as well, and you can also get it for their shoes. Because you
Yep.
also for this one type of shoes, you can put it on the shoe as well.
Yeah, like that one you see on the right. Yep.
So don't forget your phone. Yeah.
Yep, medical alert on your phones. I know we're running out of time. Please look this up. You can go on your iPhone and set this up. We usually try to set it up on all our patients in clinics so that they've done it. So after this talk, if you have time, please set it up. And there's ways to set it up on your Android phones as well. If you want to take pictures, I'll wait. Obviously, procedures, surgeries, childbirth, anything we want to know. We want to come up with a plan. We want to be an advocate for you. So let us know, communicate with us well in advance so we can help. Mental health, we had a whole big talk about it. It's so important and it's not given as much importance as we should. There should be a psychologist. If you're an HTC, please make use of them. Use them as your therapist. It may be that some of those psychologists will be able to like set up therapy appointments with you. So don't hesitate about asking for it, and you're connecting with your peers. So that's amazing. And I think that's the end of the talk.